Good morning or good afternoon, wherever you may be. Please allow me to introduce myself. I'm Ayman El-Mohandes, Professor and Dean of the CUNY Graduate School of Public Health and Health Policy. And with my dear colleague, Professor Wafaa El-Sadr, we are co-leads of the Pandemic Response Institute. This is the first webinar to be presented and sponsored by the Pandemic Response Institute in New York City, and please allow me to give you a brief background. As you are aware, New York City was hard hit by the COVID pandemic very early on, and as such, the city decided to create an institute focused on pandemic response, and ICAP at Columbia University is the operator of the institute, and CUNY School of Public Health is its key partner in this endeavor. We work collaboratively with city agencies and the community towards preparedness, prevention, response, mitigation, and recovery from pandemic situations. It is not surprising that the world is experiencing another infectious disease threat, and as such, the PRI is responding by inviting a group of experts, world experts in the field, to comment on this new challenge. Please allow me to give the screen to my colleague and co-lead of the PRI, Professor Wafaa El-Sadr.
And thank you very much, and welcome all to the webinar. And thank you very much, Professor El-Mohandes. It gives me great pleasure and I'm honored to introduce our speakers today, as well as our panelists. They are all very eminent and experienced and widely acknowledged individuals in the field of epidemiology and infectious disease. But nonetheless, I'm going to be very brief in my introductions. First, I'm going to present briefly our first speaker. Our first speaker will be Dr. Ifedayo Adetifa, and he is the Director General of the Nigeria Center for Disease Control. He's a pediatrician by training and an epidemiologist, and he's worked for almost 2 decades with vast experience in pediatrics overall, infectious disease, as well as also vaccine epidemiology. Prior to his current appointment, he was an associate professor of infectious disease epidemiology at the London School of Hygiene and Tropical Medicine in the UK. And prior to that, he was a clinical epidemiologist at the Medical Research Council unit in the Gambia. So welcome. Our next speaker, second speaker, will be Dr. Andrea Mccollum. And she is the Deputy Incident Manager for the 2022 Monkeypox response at the US Centers for Disease Control and Prevention, where she has worked since 2003. When she joined the agency, actually as a graduate student, she completed a PhD in population biology, and she also completed the CDC's highly regarded Epidemic Intelligence Service Fellowships in 2011. She's been an epidemiologist at the CDC's pox virus and rabies branch since 2009, with a focus on pox viruses, including monkeypox. After we hear the 2 presentations, we're going to be joined by 2 panel discussants. And the first discussant will be Dr. Celia Quinn, and she is the Deputy Commissioner of the Division of Disease Control at New York City Department of Health and Mental Hygiene. And in this role, she leads the city's management of and response to a range of infectious diseases, including general communicable diseases, vaccine preventable diseases, sexually transmitted infections, HIV, and tuberculosis. She also oversees the Public Health Laboratory and the Department of Health Clinical Services and its response to infectious disease emergencies. And then lastly, our last panelist today will be Dr. Joseph Osmondson, and he's a scientist as well as a writer, and he received PhD from the Rockefeller University in molecular biophysics, and he is also as well a writer and has published widely, and his writings have appeared in the Village Voice, Los Angeles Review of Books, Gawker, and many, many other publications. And I'm also happy to say that he recently published a new book of essays called Virology, which I've read and enjoyed very much. So during the presentations and the panel discussion, I invite you all to please put and post your questions. We will hopefully, after we're done with the presentations, we'll have the opportunity to have a discussion, and we will take many of your questions, or as many of your questions as possible, to enrich our discussion. So without further ado, I'd like to hand over then the screen and the presentation to Dr. Ifedayo. Welcome.
Thank you very much. Thank you very much for the invitation. And it's indeed a great pleasure to be here. I'm just going to try and share my screen quickly. I hope this can be seen.
Yes, it looks great. Thank you.
Okay, great, excellent. Well, just to briefly highlight that Nigeria's history with monkeypox is about 5 decades old. As people may recall, following the identification of the first human case of monkeypox virus in the Democratic Republic of Congo in 1970, Nigeria's first case was identified in 1971, and then for a few cases we have seen sporadically between that time and 1977, 78, following which there were no detected cases. And 4 decades later, we had a resurgence with what's considered the emergence of monkeypox in Nigeria in 2017. That was associated with about 200 cases. Well, since 2017, which is about 5 years of dealing with monkeypox reemergence, we have learned many lessons and had a few successes in managing this outbreak, and of course, identified a number of areas of uncertainty and challenges. For the current outbreak, we had to activate National Monkeypox Emergency Operations Center on the 26th of May. And this was a few weeks after the UK notified us of our identification of a monkeypox case in the UK. I think it's the 6th of May, with history of travel or return from Nigeria. And since then, we have had an unusual level of attention given to monkeypox because of the cluster of cases recently experienced in the current global outbreak. I mean, countries that are deemed not normally endemic for monkeypox that appear to show an unusual and a different pattern from what is known about how this disease is transmitted or spread in Africa. Well, in Nigeria, we conduct case-based surveillance for monkeypox, as you would expect, which basically goes from identifying a suspect case to having samples collected and transported and sent to the National Reference Lab in Abuja. That's the NCDC's lab. So we've got centralized testing in place at the moment, but we've got a turnaround time of 24 hours from when the samples are received to test and notify the results, and then feed that back to the sub-national authorities to conduct contact tracing. At the moment, we've got no problems with centralized testing because it's enough to meet the current testing needs in the country. By way of epidemiology, this year we've had 301 suspected cases reported, of which we've confirmed 101. We sadly recorded 3 deaths. These were in first an organ donor recipient of immunosuppressive therapy, and a 40-year-old male, and then we've had a child, unfortunately, who had monkeypox and varicella zoster virus at the same time and appeared to have succumbed to interstitial pneumonia as well as what. So when we take this collectively from September 2017, when we monkeypox outbreak started, we had 813 suspected cases and confirmed 327 of those, and had a total of 11 deaths in total. When we look at the test positivity from 2017 to 2022, let's see if we're having any difference in patterns. This is what it looks like. We've had more suspected cases this year in 2022, and now more confirmed cases compared to 2017, but the test positivity remains about this. We are, of course, benefiting from increased awareness from all the airlines, headlines, as well as ongoing efforts in country to strengthen surveillance of monkeypox, especially in subnational locations that were previously not reporting. This just gives us the epi curve. Most of the cases have been identified the last 5-6 weeks, and the numbers continue to go up as well. Of course, everybody is quite keen to understand if there's any difference in what's happening with monkeypox this year in 2022 compared to the preceding 5 years. And what we can see, if we look overall or we look at the period from January to date, is that we still have a predominance of males. There are male cases. The age groups 21 to 40 is most predominantly represented among cases, and the pattern remains the same whether you look at this year alone or you look at the preceding, the cumulative numbers from 2017. In terms of the distribution across the country, we can see that in the first couple of years, most of the cases were clustered in the south. People would say, okay, this is in the rainforest areas where you're likely to have an abundance of contact with likely reservoirs. But what we can see from 2019, 2020, and up to 2022 is that we are now seeing cases reported from across even the northern parts of the country and other places that are different from the south part of the country where we traditionally saw cases. So we do suspect that the endemicity or areas where you can find monkeypox in the country are probably more widespread than previously understood. This shows the cumulative numbers, and we do have 29 of our 36 states or 37 states in the federal territory have all reported cases. So this gives us the trend compared to previous years, and already we can see that the trajectory for 2022 became really steep at the end of May, and with this momentum is projected that this will surpass the numbers we've seen in 2017 when monkeypox first re-emerged. By way of summarizing the epidemiological findings, we have not seen any evidence for any change in disease transmissibility. We clearly have noticed an association, for example, with in terms of adverse outcomes or more severe disease with HIV and other immunosuppressive conditions. We had, of course, previously documented genital lesions, but we have not documented any evidence of sexual transmission. We have not seen in 2022 any unusual clustering or presentation of genital lesions as has been reported elsewhere. But genomic surveillance carried on in country shows that all of the cases remain of the West African clade. We haven't seen any differences in clinical manifestations, whether you're thinking about the symptoms profile or virulence. And despite previous and ongoing efforts, we still haven't identified what animal reservoirs, what animal is natural reservoir for monkeypox virus. Our previous investigations have confirmed that monkeypox viruses are indeed circulating in a wide range of animals, or likely target animal reservoirs. We did not, still haven't been able to find monkeypox in any of these animals tested. In terms of what we are doing for response, I mean, we're as a National Public Health Institute, and we would touch on this, is that we have developed monkeypox specific guidelines to continue before even the worldwide spread of monkeypox. We had been investing in strengthening surveillance down to grassroots and ensuring that these are captured by our digital surveillance system. We have a centralized sample management system that was put in place not just for monkeypox, really for all of the diseases that are under our purview for the purposes of transporting samples, either for confirmatory testing or for packaging sequencing in general to national reference. As we've learned from COVID, risk communication and community engagement is key, and we continue to intervene in that area via multiple channels because we also would like to improve reporting and, of course, reduce stigma, especially given the news out of other parts of the world that relates monkeypox at the moment now to particular sexual orientation or particular population groups. We're, of course, now trying to put in place port of entry screening just to make sure that we reduce the chances of exporting obvious cases of monkeypox, or indeed increasing the risk of transmission by allowing active cases into the country without any intervention. And of course, we've adopted the One Health response in our approach to monkeypox, to Lassa fever, to all of the other zoonosis we deal with, and continue to work on animal and environmental surveillance, including work on animal and a summary of the way we've gone about monkeypox control in Nigeria is since 2017, when monkeypox emerged, we've had the monkeypox technical working group in peacetime. And since we activated the EOC, we are now using the incident management structure that includes all of the relevant partners, including the NCDC, Ministry of Health, our health services, our colleagues in ministries of environment, the animal sector, including our National Veterinary Research Institute, and of course other partners like the World Health Organization, the CDC, the African CDC, etc. We do have priority research questions. Key or right at the top of that list is the animal reservoir for infection is not known, and therefore we cannot plan any intervention in that space of animal-human interface. We believe that there's probably a lot more cumulative population exposure than my reflected cases, and we would like to document that or confirm that by doing some serology work. We are working on genomics to see if we can say more about the transmission chains, and of course also to look at changes to the virus that may suggest increased adaptation or confirm some of the other preliminary findings from elsewhere about increased adaptation to humans and to human transmission. We know very little about the correlates of susceptibility of protection or associated immunity. If you have a case of, if you had an episode of monkeypox, do you have lifelong immunity? We are not sure. We do know that there is at least one healthcare worker that has had 3 or I think 4 episodes of monkeypox. We are trying to understand the reasons for this. In view of this emerging information about the possibility of conventional sexual transmission, of course, this brings up the question about how long you might have monkeypox in semen or seminal fluid, and whether the testes might provide us sanctuary areas for this virus and result in later transmission, as has been seen with Ebola, for example. We continue to grapple with a few challenges. Of course, monkeypox is mostly a self-limiting illness that I'm sure is mostly mixed up with chickenpox. So there's a very low risk perception among the population, which also affects reporting and is correlated to the low index of suspicion among frontline healthcare workers. And of course, we need to tackle these gaps in our knowledge about monkeypox as they are highlighted. This is probably not most people's cup of tea, but again, as an NPHI, we are quite keen on ensuring that there's emergency preparedness and responses appropriately funded, for example, not just at national level, but also at the subnational level, where cases or suspected cases will be found and reported. Excuse me. To conclude, monkeypox is endemic in many parts of Nigeria. The epidemiology has been mostly stable for over 5 years since the resurgence. Much progress has been made in terms of improving prevention, detection, and response time. We are lending this expertise to the sub-region as well. Our reference lab recently hosted about 22 participants from other parts of Africa who came to be trained on monkeypox diagnosis and sequencing as well. We continue to sequence all occurring cases, and we'll share the data and results soon. We do need to ensure that we continue to sustain monkeypox preparedness and response efforts, and now make sure that we've got access to medical countermeasures, especially for those to be made available to those at very high risk, people who work in laboratories or are in the forefront of public health response, people in high risk contacts and others who have a profile that may suggest that they would have likely to have more severe disease manifestation and adverse outcomes. Thank you very much, and again, thanks for inviting me to share some of my experience about monkeypox in Nigeria. Back to you.
Thank you very much, and very much appreciate the update and look forward to the discussion. I again remind everyone, please put your questions. We're eager to receive all of your questions. Let's move ahead then with our second presentation from Dr. Andrea Mccollum from the US CDC. Welcome.
Thank you. I'm working on sharing my screen. As soon as you see it, it would be great if someone could confirm that they can see this presentation. Can anyone see this presentation? Yes.
Yes, we can see it.
Looks great.
Okay, I'll even minimize that so it's a little less in the way. There we go. Thank you for having me. It's nice to be a part of this forum. So I am, as mentioned, I'm the Deputy Incident Manager for the monkeypox response at CDC right now. And I also am sort of a resident poxvirus and monkeypox SME. So this is just a couple slides, brief situational update of where we are in the US as of yesterday. So we have 866 cases. We do continue to get a substantial number of case reports every day, including some new states, it seems like most days. And then worldwide, we're approaching close to 10,000 cases. So just some brief Epi data here as of July 10th. So this is our Epi curve, just showing the number of cases that are confirmed by week at this point. And this low week right here is just the beginning of this current week. So that certainly that bar will be higher by the end of the week. And then the age distribution. So most of our cases here are less than 40 years old. And although I don't show the numbers, the overwhelming majority, over 90%, are in individuals who have male sex at birth. So just a little perspective here. I think this is a lot of what we're grappling with and understanding what's happening right now in clinical presentation, which really is the tricky part in terms of clinical detection, right? And getting folks tested is this historical understanding of clinical presentation, which I present here, and cases in general. You know, prior to this global outbreak, 99% always had a high fever, and they all had some version of the febrile prodrome with the symptoms that you see here about 2 to 4 days before the rash onset. followed by a very characteristic rash, which admittedly, even with our historical understanding, in the early stages, the macules and papules are certainly difficult to discern as pox virus. Usually by the vesicle or pustule stage, your crust is really quite clear and should clue in clinicians. And I feel like that is very much still the same, although it's still very tricky. Rash traditionally has often been present on the palms of the hands and soles of the feet, which is really characteristic of only a few infections. So that would clue someone into pox viruses as well. And rashes were often in what we call a single stage of development on a given side of the body. So all vesicles on the arms, all pustules on the face. Illness has classically and does continue to take up to 2 to 4 weeks till resolution. And resolution is defined at the point there are no symptoms, no systemic symptoms such as fever, lymphadenopathy, respiratory symptoms, and no rash. So that means all scabs have fallen off and there's a fresh layer of skin formed underneath. The lesions themselves are almost, I describe them as like viral factories, and they are just chock full of a ton of virus at every single stage. And these are just images of what we kind of were thinking about classically. And these are some photographs taken on the left from the US outbreak that occurred in 2003. And then on the right were photographs taken from Democratic Republic of the Congo, where this virus occurs fairly regularly as well in forested regions. So here you can see sort of these well circumscribed lesions. They look like real discernible sort of circles, the border, and then particularly on the right, you see the central point of umbilication. But of course, early in the stage, as you see on the top left, it can be a little bit difficult and tricky. You haven't seen it fully develop to what you see more sort of in the center pictures or on the right. Just to note that co-infections with other infectious agents do occur. We know that they occur, and they may cause difficulties in clinical recognition. So VZV co-infections, that is the cause of chickenpox, which is actually not a pox virus, but a herpes virus, do occur, and that's regular occurrence in some areas of Africa where this virus is found. And then more recently, I think there's a real recognition, particularly with the presentation of the cases occurring in the US and in Europe that I'm aware of, that co-infections with other commonly sexually transmitted infections such as herpes, gonorrhea, and chlamydia may and do occur. So that also sort of confounds clinical presentation. Some key differences I wanted to bring up, and this still holds, is that only about 65% of the patients in the United States right now are reporting prodromal symptoms. So that means that patients are often not experiencing sort of the fever, their lymphadenopathy, the respiratory symptoms prior to rash onset. And that is really quite different than our classic understanding of monkeypox. Also, many of these patients report rash beginning on the genitals or perianal area, instead of sort of classically, we often think about lesions often presenting sort of in the oral cavity in the mouth and or on the face. Lesions are not always widely disseminated across multiple sites. Again, classically, we think about lesions on all sites of the body, on the hands, on the arms, on the feet, etc. And here, a lot of patients are only reporting 1 or 2 sites that are involved. And then importantly, and I think this is what's key for a lot of clinicians as they're thinking about it, patients may not realize that they have lesions at certain sites of the body, and they'll initially see a provider due to reported symptoms of anal rectal pain or tenesmus, and physical exam findings have revealed visible skin lesions, and then certainly concerns for proctitis. There we go. And then this is just more recent photographs that are courtesy of UK Health Security Agency and are available online of what these lesions look like and how they may be slightly different. From a pox virus perspective, I actually think a lot of these look very classic, but of note, they are very small and they may be a little more difficult to discern compared to classic presentation. And certainly if you're not used to looking at these viruses routinely. So just a quick note that laboratory diagnoses for these viruses, orthopox viruses, so monkeypox virus is a species of virus within the orthopox virus genus. And that would include variola virus that cause smallpox. And so there's a couple of diagnostics I mentioned here. PCR is the diagnostics that we're using here in the US and that we use often in multiple sites in the world. And as followed by genome sequencing. So testing for suspect cases, we've been utilizing it here in the United States, the laboratory response network labs. These are set up at most state health departments, and these have been in place and ready to go for a situation, an event like this for a number of years. So that's where most of the testing has been done to date. As of last week, commercial testing had begun at one laboratory, LabCorp. And that'll be rolling out. Commercial lab testing will be available to a few more laboratories in the coming weeks. CDC is working with them on that. And I just want to note that the orthopox specific PCR test is sufficient enough for clinical action and public health action at this point, given the epidemiology and what we know that most of the cases that are orthopox virus positive would be monkeypox at this time. Samples are then sent to CDC for monkeypox specific characterization, and CDC can also perform viral DNA sequencing if needed. So transmission, just a couple of notes of transmission. This is a zoonotic virus, so it does originate in animals. The precise animal reservoirs are still yet unknown. There are a lot of hypotheses about that and some data pointing to a couple of species of interest. After it is introduced into humans, human-to-human transmission can occur, and that certainly is what we are seeing. Routes of transmission include respiratory droplets or secretions. Contact with lesions. As I mentioned before, the lesions themselves are chock full of a lot of virus and they are infectious. Infected urine and feces has been noted in animal models and could be a cause of concern with humans as well. We know that infected tissues could be around as well. Fomites, sort of surface contamination. Orthopox viruses are extraordinarily hardy viruses, and then transplacental transmission. If there is a pregnant individual, the virus can be transmitted to the fetus. And again, patients are infectious until the crusts separate and a fresh layer of skin has formed. So just jumping into a little bit of the data that we see here in the US, what we're seeing right now in terms of transmission is very consistent with what other areas of the world are reporting, and that is transmission amongst primarily being reported amongst sexual partners. And this is just of 57 individuals with reported data on the number of male partners in the previous 3 weeks prior to illness onset. This is what the data looks like in the US, where most people are reporting sort of less than 6 partners, but it certainly does. Most people are reporting more than one partner. And then in terms of venues or sites or how people are meeting sexual partners, so amongst 61 men to date, this is what they're reporting. And I think this also is consistent with some of the reports out of Europe and even Canada. So there tends to be a use of apps or going to clubs or other venues for our sex parties and such for meeting individuals for this purpose. So prevention, I think it's these are sort of classic public health measures. And of course, when we're dealing with a number of cases across a lot of states and an increasing number of cases, they are admittedly becoming more challenging. But certainly we want to make sure that clinicians are able to quickly recognize cases, complete a case report form and get them tested and confirmed. Once confirmation, again, orthopox virus confirmation is sufficient, that's sufficient to suggest go ahead and ensure that the patient understands what the test result is, and isolation measures can certainly presume, and they can even presume when they're suspected. So we are right now encouraging patient isolation until the infectious period is over, and that may occur within the household or a hospital unit should the patient have more severe illness and need to be hospitalized. Emphasis on infection prevention and control in healthcare facilities is really quite critical. We know that from previous monkeypox outbreaks, not only in Africa, but some of the cases that have presented previously, one of them in UK, that healthcare workers are at risk of infection just due to the nature of what they do in caring for patients and having that close, sustained contact with a patient. certainly want to proceed with contact tracing. Community engagement outreach is really a big piece of what we try to do at CDC, and I know others have as well. And sort of that's a broad sweeping community engagement, for example, all of the US public, and then having more targeted engagement either for providers, for health departments, or for particular populations that may be at risk right now. And just a quick note here that previous smallpox vaccination does provide protection, and what you're hearing about vaccination right now, we are using the terminology monkeypox vaccination, and that is correct, but that is all built out of smallpox vaccination and smallpox preparedness. So with that, I'll transition just briefly to talk a little bit about the medical countermeasures that we have on board. So these are the two vaccines that we have, Jynneos and ACAM 2000. Jynneos is a vaccine that did not replicate efficiently in human cells, and it has a really wonderful safety profile. It's a 2-dose series. So this is a vaccine that requires administration at what we call day 0, and then a second administration 2 days later. And then the other option on board is ACAM 2000, and this is sort of reminiscent of those traditional smallpox vaccines that left a scar on the arm. And this is a replicating vaccine. It has a very different sort of profile in terms of risk benefit, and a different profile in terms of the individuals who may be willing or not willing, able to receive this safely. So we have begun to roll out different suggested strategies for vaccination here in the United States. And so we kind of think of them as 3 sort of different types. So there's post-exposure prophylaxis. That was what we started out with initially in terms of the response, and that was recommended to identify your contacts. If you have intermediate or high-risk contacts, post-exposure prophylaxis is provided 4 to 14 days after exposure to try to prevent infection. And this is still a strategy we are pursuing. We are beginning to transition, and we've begun transitioning, and many of the larger cities, including New York City, Chicago, and Los Angeles, have begun expanding it out into what we call expanded post-exposure prophylaxis. So this builds on the initial criteria of identifying these high-risk exposures, but also thinking about individuals who with certain risk factors who are more likely to have been recently exposed to monkeypox. And that definition may differ depending on what jurisdiction you're in, but some have restricted that to, for example, individuals who self-identify as having male-to-male sex in the previous 14 days in a certain area of the city, recognizing that that's the population where transmission may be occurring more frequently right now. And then the third category is pre-exposure prophylaxis. So this would be provided to someone who is at high risk for monkeypox. Currently in this country, that is restricted to individuals who meet an ACIP criteria, and it's really geared around occupational risk of monkeypox infection, and with a special emphasis on laboratorians who may be handling samples. 2 other products I wanted to talk about very briefly are treatment products that may be considered for an active case patient. One is TPOXX, which is an antiviral medication, and this is being used in a large number of individuals right now here in the US, and I believe in Europe as well as Vaccinia immunoglobulin intravenous VIG, and that could be used as well under certain considerations. And certainly CDC has clinicians really at the ready, more than happy to talk through specific case consults or any questions you have about any of these products. And then I just so you know, these are some of the treatment guidelines for people who you might consider to need for administration, of TPOXX or VIG. And these are individuals with risk of severe disease. And so I list those out here. And then to date, this is just as of, I think 2 days ago, what's been distributed here in the United States for use. And of note for TPOXX, that's the oral tecovirimat, 107 patients have received oral tecovirimat under an IND that CDC can provide at this time. So my last slide, there's a lot about this in the literature and on the news, and this is my own perspective, really. So what makes this so different? So certainly there's a large number of cases in multiple countries outside of where this normally occurs in Africa. And many of these cases, but certainly not all, are individuals who report as men who have sex with men. And I do want to emphasize that this is a sort of a population where there is sort of transmission occurring right now. This is not a virus that is limited to gender or sex. This is a virus that can infect any individual person. Clinical presentation, I kind of hinted on this earlier in my talk, and this is something we are really trying to grapple with, get a better sense of. Clinical case reports are beginning to come out in the literature, and we are strongly encouraging clinicians here in the US, if you have any interesting observations, case series, et cetera, getting those out in the literature, and in forums like this are extraordinarily helpful. And the reasons for the unusual presentation are really not well defined at this time. There's a lot of hypotheses on the table, but in terms of a scientific approach to being able to identify that, we're in the early phases. There's more to come. So with that, there's my information. You're welcome to contact me if you have any inquiries. And with that, I will end my talk. Thank you.
Great. Well, thank you very much, Dr. McCollum. And I invite our two panelists to join us at this point, Drs. Quinn and Dr. Osmondson. So we have received several questions, but I'll start first by asking maybe Dr. Quinn first to just give us an update on the situation in New York City in particular with regards to this outbreak. Thank you.
Thank you. Thanks, everyone. Yes, I'm happy to be joining this panel and look forward to the discussion. So within New York City, our first case associated with this outbreak was diagnosed in the middle of May. And as of yesterday, we're now reporting 223 people that have tested positive for orthopox virus, with really a lot of acceleration just over the past couple of weeks. We definitely expect that there are other cases that have not been diagnosed because of a variety of challenges that people have in presenting for care, accessing care, and getting tested. I will say our epi that we are seeing is very similar to what you just heard described by Dr. McCollum. It's very similar to what's been seen in other countries and in other parts of the US. I don't have completed epi on all of these 223 cases that were reported yesterday, but as of the end of last week, majority of the cases were in cisgender men who reported being part of the MSM community. The majority of our cases are in residents of Manhattan. And I'll just note that the health department is working on getting some of this data posted regularly on our website, hopefully in the coming days or week. And then I think in terms of the other medical countermeasures that Dr. McCollum also summarized, we have been offering monkeypox vaccine in the sort of extended post-exposure prophylaxis model, as well as to prophylaxis for people who are identified through contact tracing as known contacts. And we have also been working closely with the healthcare delivery system here in New York City to help people access tecovirimat when it is indicated. And lastly, I'll just comment on that the health department also has some really excellent guidance for providers around interim guidance for the treatment indications that's also posted on our website. So in the interest of having further conversation with the full panel, I'll leave it there and happy to take questions.
Thank you very much. Maybe I'll move then to Dr. Osmondson. Of course, you heard about the importance of interventions at all levels, at the national, federal, local, and as well as community levels. And maybe you can comment a bit on, maybe start with the community, maybe comment on the community level, and particularly in a situation where we're concerned about stigmatization of the population at risk.
Yeah, thank you so much for having me. And I'm very happy to report from the community. I'm a New York City resident and am a part of the gay community, queer community in New York City. And I will say that, this is a pathogen that has been described in humans for decades. There are available FDA-approved tests. There are there's an FDA-approved treatment, although it is indicated for smallpox, and there are FDA-approved vaccines, again, from smallpox, as you've heard. There is a huge amount of frustration at the level of community because although there are tests, treatments, and vaccines available, they have not been available to people. So we have a huge number of people who have had very difficult experiences accessing testing. In order to get access to treatment, one has to be enrolled in a clinical trial through an IND, which of course is very difficult for providers to mount quickly. And then vaccination has just been huge supply chain issues. So people are very interested in accessing the care that they need, but are having a huge amount of difficulty doing that. And when we expand that out to, questions of global equity, it becomes much more frustrating. So I think there's people, it's very easy to avoid stigma if we can tell people, hey, if you're having this illness, get tested, get treated, have your contacts get vaccinated, and just provide the information and the ability for people to access care. The frustration is that ability to access care has so far been largely completely absent. And then we see the media and other people kind of blaming our community for transmission, when actually what our community is interested in is in care for ourselves and protecting others, and in issues of getting global access actually to all of the tools that we take for granted.
Thank you. Thank you very much. And I'm sure we can delve into this in a much deeper way. Going back to one of the issues that has been said is that this is a zoonosis, and but at the same time, people are saying it's unclear what's the host, what's the animal host, and can you reconcile? Maybe I'll ask Dr. McCollum to start first, or Dr. Ifedayo. Can you reconcile the statement that we know it's a zoonosis, but yet it's unclear what the animal host is?
Yeah, we certainly share that frustration as well, and I speak on behalf of my colleagues who have worked on this for many years. We do have some data suggesting some animals, some wild animals, particularly a lot of data from the Congo Basin in Africa and in Central Africa, suggesting that certain species of small mammals, including rodents, may be involved. These would be rodents that live in the forest or close to homes. This is not Rattus specifically, but there's really been a lack of data showing, active live virus and sort of our criteria for fully defining a specific reservoir. It's probably not a single species. It may be multiple species that are involved in sort of maintaining this virus in the environment. And we also don't want people to lose sight of, this may be, I think a lot of people talk about hunting in these environments. And this is in the Congo Basin, this virus often and disease is present in an area, very rural village communities that are often dependent on wild animal meat as a source of protein. And so, is it the purpose of hunting, or are there other ways that people are being exposed? And I think that extends into areas of West Africa as well, and thinking carefully about, is this hunting or what people might, wild game or bushmeat, or is this a use of wild, contact with wild animals in other ways, or with products made from wild animals as well? So we have to think broadly. It's an open area of research and questions. I don't know if Dr. Adetifa would like to add to that.
Well, just to confirm the same frustration and to highlight the fact that we interestingly, a lot of our cases don't have any history of recent contact with animals or the like. So that makes it a bit difficult. Mm-hmm. What we know is that the entire family, the orthopox virus family, members of the family are circulating in the animals we've studied, but we just haven't found monkeypox itself. And then, of course, to take us back to a bit of history, the sort of before this current outbreak, the previous largest outbreak of monkeypox in the United States, for example, was associated with animals that were brought from West Africa that I think may have infected prairie dogs and the like, who then went on to infect humans. So we're not clear. In fact, the name monkeypox is a bit of a misnomer because the monkeys are not really the natural reservoir of the virus, even if they may have been first found in a group of imported monkeys. But we'll continue to try and get answers to this particular question because it is essential really for public health. And what we expect will continue to be the increasing risk of zoonotic transmission of pathogens to humans, including monkeypox, of course. Thanks.
And it does make sense. And I note that the approach you're taking in Nigeria is a One Health approach in recognition, of course, of the importance of the One Health approach in this context in particular with such a zoonosis. I just wanted to maybe a couple of questions on transmission and concerns about particularly respiratory route. I think there's been a lot of concern about the direct skin-to-skin contact versus possible respiratory transmission, as well as also some people are raising a question about is there any evidence of actually transmission or acquisition from someone who has no symptoms or someone who's unable to link back to somebody with symptoms. And based on the data you have, maybe I'll start from you, with you, Dr. Quinn, in New York, and then go to experience in Nigeria and then the CDC.
Thanks. Yeah, I'm very excited to hear what the other panelists have to say about this question, because I think it's one that we have an active interest in, especially in terms of how it impacts how we talk to people in the community about what the risks are. We have not had transmission within healthcare settings, and a lot of the transmission that we are seeing, we think is related to the intimate contact and contact with sexual partners. We have had some reports where the exposure may have been with someone that did not have visible lesions, but I think we need to investigate those cases really carefully, because sometimes lesions, as you heard earlier, could be internal, or sometimes the lesions could be not that visible when they're in the macular-papular stage. So this is something that we're actively looking at.
Maybe I'll ask Dr. McCollum, do you have any insights based on the cases you've investigated that would give us further information on transmission?
We have a lot of questions about transmission, as Dr. Quinn brought up, and really getting more precision on it. We do know that respiratory secretions can be infectious. The extent to which they're infectious and at what point during the course of infection they're infectious is something, a very open question. There's really fairly limited data on it from humans and animals. And it was traditionally thought of, particularly from smallpox, which is a closely related virus and presents very similarly, is that when individuals first had rash sort of in the mouth and those lesions, and remember those lesions are infectious, that subsequently the saliva in the mouth may also sort of pick up infectious virus, and then that introduces the potential for respiratory secretions to be infectious. We are not aware of any data, strong data or evidence of aerosol transmission in this virus. This is that is not known. There's really been no data on this. There's been no epi evidence of this in the last 40 years. We would be concerned about aerosols in specific instances where, for example, in a healthcare setting and a specific procedure was being done that might artificially generate aerosols, and that would be a concern. But in the community, no, that's not really a concern at this point. In terms of the lesions themselves, Dr. Quinn mentioned, maybe not recognizing that a lesion is present or the extent at which they're infectious. And certainly we encourage patients to keep those lesions sort of covered and prevent contact with other individuals. And even with surface contamination is a problem. Thankfully, though, there's a lot of really good household products that can be purchased to decontaminate surfaces really, really easily as well.
So I'm wondering, and I invite the panelists, you can speak up and just follow each other if you want to comment on each other's observations. But Dr. Adetifa, do you have any insights on the concern about transmission through respiratory route in particular? Any insights from your experience?
We do not have any sort of evidence of respiratory transmission. We do recommend mask use and use of appropriate PPE in healthcare settings for looking after patients. And what we hope to do is to, in the coming weeks, maybe include the collection of nasopharyngeal or similar respiratory specimens alongside the usual samples from just to see if we can actually confirm the presence of the virus in the respiratory passages, in which case then obviously this confirms the need to watch out and exercise appropriate care for transmission or for preventing transmission, especially in the healthcare settings and elsewhere. Back to you.
And maybe going back, I think someone raised the question is, do we have the possibility or is there work to develop diagnostics that to be used, for example, for oropharyngeal or specimens, as particularly in people who are in the prodrome of this illness. So I don't know, Dr. Osmondson, you raised that question, and maybe CDC, you have an update on this issue.
Yes, absolutely. We would love that. We do. I mean, we have the diagnostic assays. We just need validation on them on the specific specimen type. So certainly, that's certainly an area that we are actively working to pursue and hopefully quickly validate.
Great. Okay, let's maybe move on to another issue, which is the obviously we've had the endemic monkeypox infections in Central and West Africa, and now this global outbreak that's happening now as we speak and accelerating actually. Maybe Dr. Osmondson, do you want to comment on your thoughts in terms of what's happening here?
Yeah, I want to remind everyone, as a virologist, viral spillover happens on every continent, and this is not something unique to any region of the world. What I do notice is that there are often narratives of viral spillover happening in some regions and then sort of infecting the rest of the world. And I would like to remind folks that, there has been vaccines to prevent this virus available. 28 million doses were thrown out of the national stockpile as they expired and were not offered, for example, to the endemic region where they could have been used to stem what has been an ongoing epidemic there. So, infectious diseases remind us always that all regions of the world are connected. Viral spillover anywhere is a threat to us all, and that everyone deserves access to care, regardless of what region of the world they live in.
Thank you. And that's really important to keep that in mind. And I'm wondering, Dr. Adetifa, from your perspective, in terms of availability of vaccination, particularly for contacts or others at risk, how is the situation at this point in time in Nigeria?
Unfortunately, we don't have access to countermeasures. We don't have access to vaccines or to antiviral treatments. So both myself and the Director General of our National Immunization Program have made purchase to WHO and the US government to basically discuss access to vaccine doses. And we have been assured that, the WHO, once they've worked out a framework for providing access to vaccines, that would provide a means for countries to access vaccinations. Also, we have had back from our colleagues in the US CDC and are discussing potential in terms of quantities of countermeasures that might be needed. So that's where we are at the moment. We basically would like to have something in place for what would be at the moment the sort of relatively small proportion of people who are likely to have severe disease or increased risk for hospitalization and deaths. Back to you.
Yeah, thank you. I think another question that's been raised about the protective effect of prior smallpox vaccination, and I'm curious, for example, that in most of the cases, certainly the ones you showed us, in Nigeria have been in younger individuals who've not received prior smallpox vaccination. So just your comments about what are your observations on the residual protective effect of smallpox vaccination. And then you mentioned in your presentation that there's an individual who had I believe you mentioned somebody who's had repeated infections. Has that been reported previously? Because that's a question that comes up all the time.
Well, so starting with this latter question, in fact, I just was reminded to ask updates from colleagues in our what we're trying to do is to go back in time to find all of the positive tests from this particular individual and sequence them to see if we're actually talking about new infections or if for some reason actually have a persistence of infections. And hopefully we will get to the bottom of that soon. But yes, we do have, interestingly, a healthcare worker who has had at least 3 confirmed episodes of monkeypox in the last couple of years as well. Now I've forgotten what the first question was. Sorry.
Smallpox, the smallpox vaccination. The history of prior smallpox vaccination.
Yeah, yes. Well, as you rightly point out, 21 to 40, we've seen most of our cases are invested at 21 to 40 years old. Some of them, the older ones are not, even the older ones are not likely to have received smallpox vaccination, which I think stopped in Nigeria in 1978 or thereabouts. So we do not know. It's a question of whether now we've got enough accumulation of immune or susceptible population, so are likely to are now at increased risk of monkeypox. But the short answer is we don't really know. It is proposed as one of the reasons why we suddenly had the reemergence of monkeypox. But again, we've got to also put alongside, perhaps there's been low-level transmission that the surveillance system has not picked up over time. We also know that Nigeria is in the news for monkeypox, but that again is sort of punishment for success in having surveillance that actually picks up cases. We know that many countries in the sub-region don't actually have diagnostic capacity for monkeypox and therefore cannot report. So and as we've seen, even the spread of cases in countries that are not typically endemic, you do see that our surveillance systems are only as good as people report. Sometimes you've got transmission in the background that are not immediately picked up as well. So again, these are some of the reasons that we think contributors to the current situation that we have. Back to you.
Yeah, and I think that's the reason why I think there's a fear that we're only seeing the tip of the iceberg of cases that are symptomatic and come to the attention of providers, or they seek care, but we really don't know probably the full picture, the full epidemiologic picture of the situation, whether it be in endemic regions like Nigeria or in outbreak situations like here in the United States. And I'm wondering, Dr. Quinn, maybe you can comment on thoughts in terms of what would you think would be ways of trying to get a sense of, how much transmission has been going on, and can we get a better sense of the actual penetration of this virus in our communities?
Yeah. It's such an important question. One thing that the health department is doing is that we've started doing a serology study among patients that present to our sexual health clinics. So we'll be doing serology on people who have blood drawn and are willing to participate in the study. We're partnering with CDC to do the serology testing. So I think that will be helpful, but the results won't be there soon enough to give us an answer this week or even next week. I think those kind of studies with serologic testing of different populations would be really valuable in this circumstance, not just for New York City, but really nationally. So I don't know if Dr. McCollum also wants to comment on how her group is thinking about this question.
Yeah, thank you for that. I think we're certainly, I think what Dr. Quinn brought up is a really good way to approach it. We're also looking at sort of specimen remainders from other studies or from STI clinics that would be used for surveillance purposes occurring prior to sort of July, to try to better understand, has this been present prior to May of 2022 or is a more recent event, and to what extent it may or may not have been present. As well as, so we're trying to set up a series of studies as well and engage with investigators who are interested related to some of these questions Dr. Quinn brings up. I think it's really tricky, right? And I think it's, we certainly, first and foremost, would want people to be seen if they're sick and get the care that they need, whether it be monkeypox or something else. And then from there, we can begin to build a better understanding of what's really happening.
Well, can I just...
Yeah, go ahead, Joe.
I think there was data out very recently from Belgium on remainder samples that showed that people who were not reporting monkeypox symptoms did have those swabs from, I believe they were May of this year, test positive. So that is a hint that there may be some asymptomatic cases or mildly symptomatic cases that are unaware of the disease. The community is also responding. I'm partnering with epidemiologist Celia Quinn at Harvard to mount our own study, actually, that will not look at samples, but will look to the community for answers. We're launching a large-scale survey in New York City that will be a questionnaire that will ask about monkeypox symptomology. And the other thing that it will do is will ask people to send the survey on to their social and sexual networks, and ideally build a network of both social and sexual connections so that we can understand the sexual connections and the network through which this virus may be spreading. And it also will ask questions about vaccination. And so it will try to address, are the vaccination efforts actually targeting those people and those places where the virus is most likely to spread? And if not, how can we get vaccination to those individuals and or those places where the virus is spreading? So one thing that I keep reminding folks in this epidemic is that, Calypso is an African queer person. This is a community-led effort. We actually have experts in our community who are responding to our community's frustration and are building out, using our own expertise, tools that alongside the federal government, we hope will help address this. And that has built in, because it's from community for community, built in from ground up issues of equity and actually making a difference in the people most impacted by the disease here and around the world.
I think I'll add, I think Joseph brings up really great points. And this is a situation, much like many public health situations, where we have to come at this from different angles and think broadly and think collectively. And I think that's great. That's really great to hear about. I look forward to seeing the results from that.
And I think
you can find the survey at respondmi.org.
And I think there is great urgency. I think there's a great fear that if we don't act fast, is that what ends up happening is you get this infection potentially becoming entrenched and transmitted within certain communities. And we don't want that to happen. So I think rapid action in terms of all the efforts, as well as in terms of obviously diagnosis, clinical care, prevention, as well as also research efforts to answer these questions are really vital. I have a question. I think there are at least 2 pediatricians on this webinar, and I know that certainly we've heard that the monkeypox infection tends to be more severe in children. I'm wondering, Dr. Adetifa, if you have experience from Nigeria and regarding this particular issue of concern, and whether we have any cases in the United States that we can speak about at this point.
Well, we haven't had enough cases to reach that kind of conclusion yet. We sadly have had some pediatric, some deaths in pediatric cases, and they've always been associated with severe disease or with comorbidity. Like more recent death, sadly, was in a child who had interestingly, both confirmed monkeypox and chickenpox at the same time, and then had what seemed like an interstitial pneumonia or pneumonitis as well that was associated with the outcome. But we haven't seen that again because, of course, most of our cases have been in much older population, and most of the deaths and severe disease have been in those with immunosuppression, either from HIV/AIDS or from immunosuppressive treatments.
Yeah. Thank you, and I think that's another question that remains to be answered, because I know that one of the deaths you reported was in a child.
I just wanted to ask a question based on Osmondson's most recent remarks, I think, which are quite pertinent and important. But I'd like to direct the question to Dr. McCollum and Dr. Quinn regarding the communications campaign regarding the monkeypox outbreak and how we are reaching the communities at risk successfully. One of the things that we learned from the COVID pandemic is the communications efforts are very important, and that misinformation can also be disseminated very quickly. And we need to be able to preempt that in order to reach the right community with the right information at the right time.
So maybe we can start with Dr. McCollum and then Dr. Quinn. Go ahead.
Yeah, I wholeheartedly agree. And unfortunately, I can't really represent all the depth of knowledge in terms of the comms side of our response. But we certainly have begun to attempt to do that on our website. We've been reaching out. We do a lot of partner engagement weekly with a variety of calls, webinars, et cetera. And this is an area of engagement of our response we are actively pursuing and expanding on as well. Dr. Quinn?
Yeah, thank you. It's a really important part of our response and something that we're investing a lot of time and effort into, largely building off of existing relationships that the health department has had through many years of work in HIV, STI that works with these communities. Was just on a town hall with the state and city health commissioners yesterday, talking about this with organizations that serve the LGBTQ plus communities in New York State and New York City. But with something we're always looking for more input on how to do better and how to reach the more harder to reach populations, both for this and for our other public health priorities.
And from your perspective, Dr. Osmondson, I'd like to hear you also give us insights there.
It's very frustrating for us because we don't, at first we started doing outreach to the queer community, and then we had to come back to the federal government and say, we don't just need outreach, we need care. We need tests and vaccines and treatment. And the notion that this is a mild illness when one of my very good friends has so much pain from his proctitis that he can't sleep at night and can't access TPOXX, which is a medication that is FDA approved and in a stockpile, 1 to 2 million doses. We have 800 cases and 1 to 2 million doses of an FDA approved drug that no one can access. So outreach is one side, but we need to provide the resources such that that outreach isn't just, if you're sick, stay home for 4 to 6 weeks, right? We see from COVID how difficult it is to get someone to isolate for 5 to 10 days. And we are asking people to isolate sometimes in excruciating pain for weeks when there's a medication sitting on the shelf that could shorten the duration of illness. And the only way to access that medication is through entering a clinical trial. We want that clinical trial to occur, right? We learned from the HIV/AIDS crisis that you need the best science as quickly as possible. But having that be the only mechanism through which people can access an FDA-approved drug, at this point, this far into the crisis, we're saying that's unacceptable. And so, yes, we of course are willing to partner with the federal and city and state government and work with them to get the word out. But we also need to understand that they are actually working with urgency. The TPOXX thing could be, that's not by law. That is the choices of federal government between the FDA, HHS, and CDC that is saying that's the only way to access that drug and get it out of the stockpile. So yes, we are partnering with our communities. The queer community has a huge history of getting the word out to our community when there is a public health threat. Of course, people often fall through those cracks even, but until we have access to care, and access to real tools of harm reduction and the ability to educate people on what they need to do and how to minimize risk, and then what to do if they are infected, we need those tools. And without those tools, it's very difficult to message to people, because what we say, if you get monkeypox, you might not be able to get tested and you have to stay home for 6 weeks. Like, that is not going to be an effective outreach tool, right? We need to give people access to care and options on how to minimize risk to themselves, to their roommates, to their social and sexual networks.
And in a way, I mean, we've learned also the hard way the importance of test and treat, and the principle of test and treat. And it was heartening for me to see that in New York City, for example, having the testing for SARS-CoV-2, and if you test positive, you're handed the antiviral. So, and we've learned that from HIV, we've learned it from COVID. So I do, think that it's something that's really critically important. Both in terms of treating people who are suffering, but also it may have quite a beneficial effect in terms of decreasing the risk of transmission to others as well. So is there, maybe Dr. Quinn, not to put you on the spot, but has there been conversation about this principle of testing and treating for this outbreak?
Yeah, well, first, just want to really appreciate Dr. Osmondson's comments, because that has been one of our challenges as well, is when we're doing community outreach, the need to have things to offer as part of what we're communicating has been a real challenge. Mm-hmm. The treatment thing, I think I mentioned this in my opening comments, but we have been working really closely with our local hospitals and health systems and academic healthcare delivery system to try to make this a little bit more accessible, but it is not scalable. And that's the problem that we're facing over the next couple of weeks. And we're definitely working with our federal partners to communicate what the situation is like on the ground here in New York City. And it's not something that's within the local government's power to directly change. But it is the major issue that we're going to be facing over the next couple of weeks, even more so than we've managed to provide and connect about a quarter of the cases within New York City to treatment so far. And just with the way that the cases are increasing, it's going to be a real challenge over the next few weeks.
And we have the opportunity, obviously, and the luxury of having the sexual health clinics in the city, which can be a great venue to be able to disseminate and scale up treatment.
Wafaa, can I just add something?
Go ahead.
Very, very quickly on that as well, in terms of federal partnership. I'm already hearing from folks in DOH that those sexual health clinics provide essential sexual health services. And that is, we are sort of losing some of that as they are full steam ahead on monkeypox. So we really need federal investment, like we saw with SARS-CoV-2, to help strapped local departments of health actually get the vaccine into people's arms. Strapped infectious disease doctors actually have the burden of paperwork go way down to get people the care that they need. So we need that type of urgency and investment at every level of the federal government, because cities and states can't do it alone, and neither can the community.
And I think at the same time, we still continue to have a COVID-19 pandemic as well. So I think it's this is also, I'm sure, stressing both the public health entities, as well as, of course, stressing the community organizations that are trying to tackle both of these threats in our communities.
Could I ask another very simple question?
Go ahead, Dane.
Yeah, I just wanted to know, what is the turnaround time currently for the test, for the monkeypox test in the clinics in the city?
Can we also get Dr. Adetifa to respond to that after Dr. Quinn answers that question, the turnaround time for diagnostic tests?
For diagnostic testing. Thank you.
Sure. So in the past week, I could just speak to the public health laboratory. So all of the specimens, until the middle of last week, all of the specimens in New York City were being tested with at our public health laboratory. And in the past week, as the demand has increased, we've increased our capacity daily capacity, but we've also had our turnaround time go from 2 days to closer to 4 days. As commercial laboratories have come on, I can't speak to their turnaround time from like for specimens that are going to the commercial laboratories.
And Dr. Adetifa, from your perspective?
So turnaround time for once samples have been received in the lab is 24 hours. The aim is to get the samples to the lab from sort of all over the country within 24 to 48 hours. And we do have a sample referral system in place. Sometimes it doesn't quite work as well as we want it to in terms of sample pickup and delivery to the reference lab for testing. But once samples get to the reference lab, the test turnaround time is 24 hours to getting a result. And we are actually in the process of trying to contract for third-party logistics for sample specimen referral. And this is not just monkeypox, it's the same system that transfers all of the samples that need to be gotten to our reference lab as may be required. There's a question from Joseph Osmondson about the need for medications in the endemic regions. Yeah, I mean, I've followed the conversation quite interestingly with great interest. And of course, couldn't help but just see the contrast in. I mean, we have zero access to countermeasures, and then you've got a system where there is access to. There are countermeasures available in stockpile, but then you still have access problems, and almost a bit of sort of starvation in the midst of plenty, like you get, I don't know, diabetics or other situations. But we think our interest in countermeasures, obviously, is to offer some alternative to those that are at increased risk, either mostly, but of course, occupational exposure is one big group, but then we have contact or case profiles that we know are associated with increased risk of severe disease or indeed deaths. And it would be absolutely nice to have medication to give them to avert those outcomes. I mean, yes, the belief is it's a self-limiting illness that just goes away, but we have had a few people who have who get it wrong, who are a bit unlucky in the roll of the dice, and it would be nice to have some something to offer to make to reduce the chances of suffering and of course of death.
I have a question.
And actually,
can I ask a quick follow-up on that? We're hearing lots of case reports in the US of people having incredible pain and proctitis. Dr. Adetifa, do you see that as well, or is it a more mild illness in terms of pain, which is sort of what we had thought about prior to this epidemic?
No, we don't have the same experience. We're not seeing proctitis. We're not seeing anything more than the sort of usual genital area involvement in the rash. We already established long before this outbreak elsewhere that people can have genital lesions, and of course, close contact. And as a result, close contact during sex means that transmission can occur that way. But that has not changed in terms of the patient profile. And of course, the discomfort needs to be managed wherever the rash is, as the case may be.
I think we're getting close with our time. I'd like to, as give a last question to all of our speakers, and if there's one, I'll start with Dr. McCollum and then move across my screen here. But if there's one thing that you think would be probably the highest priority at this point in time to deal with this this outbreak from each of your perspectives, what would that be? And maybe I'll start with you, Dr. McCollum.
Gosh, it's so hard to pinpoint a single one, but I'll have sort of a larger bucket, and I think it's access to vaccine and treatment, and that would be across the board, in an equitable fashion, not just here in the United States, but internationally, and particularly sort of in areas of Africa where they do see this routinely.
Dr. Osmondson, please, from your perspective.
That stole my answer. This crisis just shows us that we cannot continue to ignore suffering anywhere, and it's a choice.
Thank you. Dr. Quinn.
Hard to argue with that being the most important thing. But I think we also need some answers to some of these questions that were raised during today's panel about the transmission of this particular virus and, what are the highest risk modes of transmission and how it can be prevented.
Thank you. Dr. Adetifa, from your perspective.
Well, I think it's important that we, again, learn lessons from COVID. I think if we picture the alternative reality is that if we had as much investment or attention given to monkeypox when it first popped out in 2017, and I'm by no means trying to absolve national governments of their responsibility for their own national health security, but again, the nature of infectious diseases is that we are not safe if any part of the world is unsafe. The most parts of the world are accessible by one flight, capital to capital, within 6 to 8 hours. So if we had the investment, the attention to some of these questions, which are the same questions that have been pending for the last 5 years or beyond, perhaps we would be in a better place in terms of our understanding of these issues in relation to monkeypox than we are now, because we are still talking about the same gaps in our knowledge that have been there for the last 5 years. But disease was considered our problem down here, and of course it's the narrative, which is changing. It is all about this petri dish of infectious diseases that is a risk for the rest of the whole world that needs to, either we ignore them or just impose travel bans as the case may be. Pathogens don't respect boundaries, don't respect, it's a matter of survival for them as well. So I think we need a bit more global solidarity to pay attention to what's going on everywhere. We will only travel fast, same goes if we travel together. So.
Thank you. And Dr. El-Mohandes, do you have a priority from your end? You're muted.
If I got $1 for every time I needed to unmute myself, I'd be a millionaire. I just need to say that Dr. Osmondson's remarks are most important and relevant. Responding to the community's needs, as we learned from COVID, is the only way to move forward. And rapid testing, treatment is the only way to control this outbreak. And I know that we hopefully will have learned from our most recent experiences, and I hope we can act on it, as he eloquently said. This is something beyond a city and a state. This has to be a federal response, and the sooner we respond, the better. And I thank you all for your excellent comments today.
Yeah, and I think beyond even a federal response, I think it has to be a global response. I think there's so many countries that are affected, and particularly, of course, the countries that have suffered the endemicity of this virus for decades. We have to come together as a global community, and we have to act fast. I fear that if we don't, we're going to be repeating history and repeating the mistakes we've made before. But I do appreciate everyone's commitment on this call, both here in the United States, as representing different entities and different perspectives, as well as, of course, our friends and colleagues in Nigeria and in the African continent. So on behalf of New York City Pandemic Response Institute, the PRI, I want to thank you all for joining us today. I want to also thank our audience and for the excellent questions you submitted. We didn't have time to go through all of them, but we certainly hope that you will join us again in other webinars in the future. And we will be posting this recording of this webinar. So please feel free to share it with your communities and your colleagues and your friends. Thank you again, and have a good day, everyone.
Yeah. Thank you all very much.
Thank you.
Thank you. Thank you.
Thank you.